Welcome everyone to Grand Rounds. I want to make sure that we have as much time as possible for our talk, so I'll go ahead and get us started. I'm Maria Moloto. I'm one of the environmental faculty in the department, and again, really excited to see you all. For our Grand Rounds today, we are having a talk called Beyond Proficiency, Reclaiming Family Medicine Goal Aligned Practice. Dr. Dominic Tapia is going to be presenting. Dr. Tapia is a family medicine resident physician with roots in rural Arizona and a decade spent in the Pacific Northwest. Before entering medicine, they worked for 7 years in environmental public health, gaining a deep understanding of how environments shape well-being. Volunteering in hospice care taught them of living fully and caring a deeply demanded care, guiding their current approach to patient care. Their clinical interests include chronic disease management, preventative medicine, mental health, substance use treatment, queer and gender-affirming care, perinatal care, and hospice. Outside of medicine, Dominic enjoys art, sunshine, and spending time with loved ones and their dogs. Thank you.
You're going to take him, come sit in. That way, no. All right, good afternoon, everybody. My name is Dominic. I'm a PGY2 here at Family Medicine. The talk of my presentation, or the title of my presentation today is Beyond Efficiency, Reclaiming Family Medicine as a Soul Line Practice. This slide is my parody on a financial disclosure slide. I have no financial disclosure to share, but I did want to open this presentation with some human disclosure. This was something that felt important to me to share beforehand, just so my perspective is highlighted and maybe my views and approach to some of the things that I'll share in this presentation will be more apparent. The first, I grew up in a conservative Christian household during high school. I went through conversion therapy. That feels relevant to me because I feel like it caused me to really think about the systems that people are a part of, and particularly even systems that intend to do good can still cause harm. And so I look at the systems that I'm a part of through a lens of scrutiny for that reason. I have a biracial identity, and I think that seeing that contrast growing up between the two sides of my family really shapes the lens that I see inequity through. I am a first generation college graduate and physician, so I think that also allowed me to maybe see this path more clearly without having anything on me from family members who are part of medicine. My own personal values, so I try to live with humanistic, justice-centered values, and I think that shapes a lot of not just my personal life, but definitely my work life and how I approach patient care. And then, of course, something that for anyone who is also a physician that definitely has lived this experience too. But being currently in residency, at times a very burnt out resident, I feel that I'm doing this talk speaking through lenses with the experience in that regard.
Can you just make sure you project a little bit because of the
Voice.
Yeah. Those online, so they're having a little hard time.
So for the talk today, for learning objectives, by the end of this presentation, there's really just 4 main things that I hope everyone will be able to walk out with today. The first is to define what exactly I mean by soul-aligned practice. Full disclosure, this is a term. This is a term that I made up on my own, but I will get into exactly what it means. I would also like to understand the historical and systemic forces shaping family medicine, to shed some light on just how we all got here and what exactly the specialty is that we're all a part of. I want to recognize how efficiency-driven care creates an equity in our current healthcare system, and then also identify pathways to integrate this concept of soul line practice into what we're doing on a day-to-day basis. So this slide here, for me, there truly is not a day in clinic that I'm not running behind. And I think that from maybe a preceptor's perspective that I'm working with, there's lots of different reasons that might be the case in their eyes. But really for me, it comes down to the difficult tension of feeling torn between this need to be efficient and this desire to be present with patients. And I would argue that my desire to be present with patients always outweighs my desire to be efficient. So for that reason, I'm often running behind. I do frequently feel like the white rabbit from out of the lane, running between second phases. Always feeling late and a little behind. I think this is probably something that any of these patients in clinic can relate to. And if you were to reflect on a time that you felt full between efficiency and presence, I'm sure there are issues that. So for the purposes of this talk, thinking about what is soul, that of course can probably mean many different things to many different people. For the context of this presentation, I'm using a definition that comes from Thomas More, who is a PhD psychotherapist. Wrote this book called Fair of the Soul, as well as many other novels that I've really enjoyed. And I'm taking his stance on what the idea of soul is to kind of define this presentation. For him, and I guess going to a direct quote from his book, soul is not a thing, but a quality or dimension of experiencing life in ourselves. The soul is really about presence, and it's about meaning, and it's about really connecting to, I suppose, the qualitative experiences of what it is to be a human. I thought it was also important to make this distinction between soul and spirit. I think that when people hear the word soul, they do sometimes think about a more ethereal or transcendental concept, and I would say that was more consistent with spirit in this case, whereas soul is more of our everyday embodied, like lived human experience. And then to provide just some basic contrast going into this presentation, I wanted to kind of compare what my idea of soulful care versus efficiency-driven care looks like. So soulful care is relationship-driven, whereas efficiency-driven care is metric-driven. Soulful care is patient-centered rather than throughput-focused. It is time-expansive rather than time-limited. And soulful care protects humanity rather than being a system that benefits from humanity suffering. One of the key themes to this talk and these ideas that I have is that efficiency is really rooted in colonialism, and it's when Western medicine was sort of born out of colonization that efficiency really became an idea in medicine and in healthcare. And so one example of that is the colonization of clinical encounters, where we suddenly have our time, attention, and relationships controlled, whether that's by time constraints or people who can access us through appointments, insurance, those kinds of things. Our encounters now are frequently reduced to tasks and metrics and throughput. There's very little emphasis often on the qualitative piece, and that's certainly not measured in a way that allows it to be a measure of success in any kind of significant way. And then within that system, patients are at risk of becoming data points and our relationships are ultimately strained. Through this, we also have seen the industrialization of medicine, where it often feels like medicine is treated like a production line, where patients come to clinic and they're out of clinic, and there's not always time to respond to their needs completely. The profession is now shaped by standardization, there's hierarchy, there's even credentialing monopolies that all dictate how care is provided. Clinicians are again measured by our output, and then as we'll get into, there are historical roots to this that all thinking a little bit about what the cost is of efficiency culture. And so breaking it down into three different levels where you have personal costs that can be moral injury, whether that's for the patient or for the provider. You have dehumanization, where sometimes patients aren't completely seen during a visit. Burnout on the provider level, I think when we're not able to connect to those things, we end up feeling that burnout a lot more. On a community level, you end up with fragmented care. That is one of the reasons that we find that family medicine came about, was to help with that continuity. You get deep into equities in the community when efficiency is the priority, and sometimes a lot of stress for patients. On a systems level, you have workforce erosion, healthcare shortages are something that is really commonly now. Rising costs of care, and then falling collapse. And I thought this image did a good job in a completely different field of sort of encapsulating this idea that as efficiency goes up, consumption also goes up, and that's not always equal or quality. And so for me, this really brings about a moral tension. And my argument is that efficiency really isn't neutral. It does reproduce inequity, and I think it's important that we slow down to look at what that means. An analogy that comes to my mind here, which I think is something that we talk about more recently than maybe a decade ago, is this idea of systemic racism. And I think that one of the things for me that became really apparent was that to see it, you simply to recognize that systemic racism exists. Like you simply just have to see it, and once you see it, it's really hard to ignore. And I think similarly with healthcare inequities, we know that they exist, but to really see them, we have to recognize where our system is broken, and we also have to be willing to ask ourselves, what do we accept blindly? And so the way that I feel anyway, in going through medical training, is that we're trained to speak the language of justice while simultaneously being shaped to serve a system that's built on inequity. And so that warrants taking the time to examine these things. I'm going to run through a history of things. This, not all the things on this timeline, but I think the point of laying it out like this, for me, was just to see the perspective of when colonization started, when family medicine became a specialty, and there's really a pretty significant gap between those things. So starting with the colonial era and early general practitioners, so this is looking back at the 1600s to 1700s. So back then, when settlers came over, early general practitioners were primarily caring for settlers and soldiers. You also have indigenous and African killers, but they were increasingly suppressed as more and more settlers came over. And then the way that we think of modern medical education now did not exist. Apprenticeships were much more common, whereas formal education was much rarer. Going through the 1700s to the early 1900s, we have the rise of specialization. So the first U.S. medical school was in Pennsylvania in 1755. The AMA, which is an organization that's probably familiar to a lot of us, was actually founded all the way back in 1847. And this is really when power consolidation within medicine started. I think this was the first organization that was really involved in sort of saying who got to practice medicine, who got valid licenses, and started to take the power that exists in medicine today. The Flexner report came out in 1910. This was a report that led to the closure of many Black medical schools and also made it more difficult for indigenous folks to be a part of formal medical education. And then over this time period, we also started to see specialists gaining prestige, and as a result of that, generalists became less common. Going through a period of industrialization and capitalism through the 1800s and 1900s, this is a period where we saw medical labor becoming increasingly commodified. As with those things, our society recognized where things could be used to produce economic advantages. We saw things like hospital tech and public health evolve, but at that time period, these were things that were most often prioritized for wealthier communities. Care at that time also became fragmented. A lot of that had to do with the formation of specialization, the formations of hospitals, and the less frequent role of community providers. And then ultimately, I think this was a deepening of the inequities that were, as we saw from the very beginning, already in place for communities who were not thought of to be included in these systems that were developing. These were some old pictures that I found of hospitals that are here in Seattle. So Harborview Hospital downtown, which is one of our own, and then Providence Hospital. Both of these at the time were actually built to serve some of these communities that were previously maybe didn't have access to healthcare. And I think that was something, by doing this research and kind of going through some of these historical things, that stood out in my mind a little bit, was even thinking of like our modern day federally qualified health centers, which I think I've just always associated as, of course, a good thing. And I think at the end of the day, like that is still the case, but I guess I never really considered maybe some of the sinister roots of like, why exactly do we have healthcare systems that serve these populations? And really the reason for that is because they were historically left out and needed a place to go. Going into the mid 1900s, so the 1940s through 1960s, is really when family medicine had its beginning. It was in the late 1940s that the DFM, I think technically had a different name at the time, started planning, and it was 1969. I think this is the typo here. 1969 when family medicine was recognized as a specialty. Some of that, from the information that I've gathered, was from a general practitioner shortage post-World War II, this sort of fragmentation of care that was happening, and a group of people who have goals of restoring generalist community-centered care. And that has all led us into family medicine as we know it today. That was looking at sort of this point that the country that we're in now started having settlers from other parts of the world. But I think looking even further back from that, it's important to recognize that there were people here that had healing systems in place that predated modern medicine by thousands of years. Those healing systems were holistic, they were community-centered, and they had systems all of their own. And a lot of these principles are things that are reflected in modern family medicine today. Similarly, you have people who are brought from their home country to this land, these African populations who also had healing practices of their own and carried that knowledge here. Similarly, holistic, community-centered, had systems in place that involve different ways of caring for people, physically, mentally, spiritually, that persisted throughout time. And again, I think the key thing here is that these are also reflected in some of our modern family medicine principles. On these notes, just thinking of contemporary scholars, there's a list of people who are continuing to expand our understanding of these historical roots, as well as thinking about paths that we can take to move forward with maybe integrating some of the things that we were not able to in the past. And really this slide is just to highlight that there's all kinds of people out there who are thinking about these things. And ultimately, I would say that why these voices matter, because I think that the way I think of family medicine is that, yes, we are here to sort of bring back that community-centered, patient-centered care, but this is not like a new or a novel thing. And so my argument is that systems like this existed long before family medicine. This is really just a resurgence of trying to bring back healing that is relational, that is community-centered, and that is culturally rooted. And so my argument would be that this is less about creating something new and more about remembering really what healing is supposed to be about. So again, family medicine's future is less about more about remembering and less about inventing wholeness. It's about integrating marginalized knowledge that existed long before our specialty, and it's about creating a practice that ultimately serves people. This I see as something that's related, that I just wanted to touch on as well. When I look at our healthcare system and think about the barriers to doing this kind of work, I think about just how the providers show up in their day-to-day work and how a part of that is also allowing for providers to be able to be soulful in their lives. And medical education is something that demands a lot out of people, and it takes away from our ability to live soulful lives. And so I think that it is difficult to expect people to show up soulfully at work when they're not able to show up soulfully in their own life at times. And so this is really just to highlight that I think a piece of sort of questioning the system is questioning the environment of the people who are working in it. And so breaking that cycle, I would argue, requires a few things. Number one is rest. Rest, I think, is a very important thing for preventing burnout. Reflection, having the time to be able to question what we're doing on a day-to-day basis. Relationships, people can form relationships with each other and with our patients. Having the time for self-care, again, being able to be present with our lives outside of work in addition to at work, being able to experience joy in life. And then the last thing, taking a stance, which to me means no matter where you're at, like on your journey, whether you're a resident, whether you're an attending, is really taking a stance to stand up for these things, and that can be in big or small ways. This is another quote from Thomas Morris's. We talked just a little bit about what it means to care for the soul, and it reads, care of the soul requires ongoing attention to the small things, our moods, our habits, the means of everyday life. So now shifting a little bit into, well, what exactly does this all mean, and how do we maybe like take this into our practice on a day-to-day basis? And I think that's something, at least in my head, where I feel like going through medical education, going through residency, I think we're really good at recognizing all of these things. I think I personally have had plenty of group discussions, lectures, meetings, where we review these things. Like, we know inequity exists, we know that burnout exists, we know that there's room to be more soulful in the work that we do, we know that there's more room to be soulful in our lives, but it sometimes feels like it stops there. And so I think this is also a little bit about just starting a conversation and just continuing to make that nudge of really thinking about, like, how do we make this shift? And ultimately, not just for ourselves, but also for the people that we're taking care of. And so I'm going to start by talking about just some of the micro shifts toward moving to a soul line practice. And we'll talk a little bit about presence, listening, rituals, and everyday resistance. So starting with presence, it really are just kind of small things that I think when you're going through a really busy day are so much harder to do than they sound on a PowerPoint slide. And these are things that even for me at the end of a clinic day, like, I will frequently just realize that I had no self-awareness to really be able to do these things. But I certainly, I think every day try and challenge myself to do them more and more. The first, like, pausing before entering a room, just gives yourself that time to, like, have awareness of the encounter that you're going into. One that I think is can frequently be overlooked is noticing our own internal state of being. Like, do I need to eat something? Do I have to go to the bathroom? A lot of times I'll get to the end of the day without having even thought about any of those things. noticing the patient's state of being. So I think, again, like if we're having difficulty noticing even what's going on in our own bodies, like how much is that interfering with our ability to really notice what's going on with our patients? And then bringing curiosity. And I think that is hand in hand with presence, just like really being able to be there and be curious about what brings this person that's in front of us. Sure. Going on to attentive and narrative listening, I think really, again, just being able to be in the room with the patient and to actually hear what they're saying. I often wonder how I will ever do a 15-minute appointment as an attending, and sometimes I think I'm literally not capable of it. But I think that to really have the time to be able to let patients tell their story, and that doesn't even have to be like their life story, but just the story about what brought them in for the visit that day, requires a period of time to be able to like give them that space to explain those things. And then for us to be able to hear that and follow that thread of meaning, really understand like what brings a person in, to have the time to reflect and summarize with that patient, and then to be able to talk about what matters most to that patient. Those are things that are often not protected in our schedules. Team rituals, I can't say that I do a lot or any of these formally, but I think that there's certainly an opportunity to. I think that probably informally some of these things come about with the people that I'm working with in clinic, for example, or if I'm in the hospital on an inpatient rotation. That could be like morning huddles where you're, prepping or talking about your patients beforehand. And I guess maybe even in a way that's not always or completely medicalized, like maybe there's some space to bring some humanity into that as well. Doing emotional check-ins with each other. I think that's something that maybe we're often better at doing in patients than in clinic. But that is something like I for sure go through probably 5 different emotions in a clinic day, and sometimes having the time to check in about that is helpful. And then having shared micro moments of grounding. I think that could also be a personal thing. And then the last, which I would argue maybe is one of the more important ones for really initiating change in our system, is the everyday resistance. And I think one thing that I think about all the time is that like the system exists because of us. Like we are the only people who can make the system work. And I don't think that we necessarily acknowledge that collective power enough. And if we really wanted to, I think we could take a stance for our patients. And I guess I also say that like completely recognizing that we all already do so much, and that could easily be misconstrued as like asking more of a group of people who are already stretched thin. But I think that sometimes that doesn't even have to come in the forms of doing more, maybe more just in the form of like demanding for our patients. So protecting time, whether that's finding ways to like push back against shorter appointment time, refusing to reduce people's metrics. So maybe thinking more about why people might need appointments for things that aren't just going to lead to a certain outcome or have some sort of an economic gain. Maybe people just need more of that time to be present with a provider. Being able to name moral injury, I think, is an important step for like identifying the source of it. And then that all just really circles back to this idea of choosing humanity over kind of throughput. And then shifting into macro shifts and just thinking of change that can be applied on a bigger scale. And these are things that require maybe a little more than just the things that we're doing on a day-to-day basis, and do require us to think more on a systems level. But I'll talk a little bit about like practice redesign, team-based care, community engagement, and advocacy. Practice redesign. So something that I think about a lot, like as a resident and thinking of going into the workforce as an attending. Also, like, well, what kind of a system am I willing to accept? And in some ways, I think of it as like the system that I'm willing to accept is also what I think my patients deserve. And so thinking about places that offer longer visit times, have maybe protected continuity clinics so your patients have more access to you, have team-based workflows so that you're not just relying on yourself to get everything done. That's something that I think working in a clinic where we have a lot of different team members is like a huge benefit. And then having space for mental health and social complexity. And I think that's something that we all probably feel on a daily basis too. Like no matter how simple a visit is, not being prepared for the social complexity that can come with just like a single problem visit. Team-based care, touched on this a little bit, but I think the idea of shared responsibility is huge. Recognizing that, you know, no matter what, our time is going to be limited, whether that's 15 minutes or we're going up to 45, like we're ultimately not going to be able to capture everything in a single visit. And so it's super helpful for me when I can say, I think I know, have an idea of what's going on with you. I know that you're struggling mentally, but I have some behavioral health colleagues who you can talk to, and they'll actually be able to spend more time, like hearing more of the details, and then having the ability to collaborate with that person, where you're still getting the information you need, but you're sort of teaming up, and in a sense, extending your time with that patient. Having potentially a broader scope of healing, I think medicine is definitely Western centric and better in this part of the country, I would say. But maybe even just thinking about how much we interact with folks who are on different spectrums of healthcare or different ends of the spectrum. I think we often think a lot about like referring out to our specialist colleagues, or maybe having people see like our other primary care colleagues in clinic. But there really are all different kinds of healing modalities out there that I think are very easy to write off when you're screening through a lens of just always thinking about everything as being evidence-based. I certainly think that evidence-based medicine is a positive thing. I'm not trying to say that's not the case, but I also think that there's a lot more to the subjective experience of healing for a patient that we don't always appreciate or respect, at least in training as a physician. And then moving a little bit into community engagement, I think this is something that also I feel probably, at least at this stage in my career, is lacking. And of course, it all comes back to time. But what are some ways that we can be more involved with our community and our practice on a day-to-day basis? One thing that I've been very intrigued by is social prescribing. That is something that's going on in various capacities around the country where people are finding ways to be able to give patients access to things in the community during clinic visits. Having partnerships again with community healers of other types, embedding our care and community needs. So I think looking out to the community to really ask ourselves, like, is the care that we're providing the care that our community really needs? Or are we pushing maybe our own agenda on them a little too much? There's probably room to be more engaged with understanding that more fully. And then, again, integrating, I think, some of that lost knowledge into what we're doing on a day-to-day basis to really appreciate the full scope of healing that people. And then the last piece, just thinking about advocacy. So advocacy can come, of course, through policy change, comes through fighting for equity, it comes from creating systems that are anti-racist, and it comes from reclaiming medicine as liberation. And in my mind, it really does mean like thinking about where people aren't being served by our current system, and I think that there's plenty of opportunity to improve there. So, thinking of this in the term, or I guess through the lens of like a movement or an institution, and as someone again who grew up in a religious household, the ways that I think of this are like for a movement, think Jesus, and for an institution, think organized religion. And that is also not to say that all organized religion is bad. That's not what I'm trying to say. But when I think of a movement, I think of something that is values driven. It's something that's coming from the ground up. It's something that recognizes like, hey, something is not right here. Hey, there are people that need to be advocated for, and that's what drives it. Whereas an institution is something that's driven by rules. It's usually cemented in the way that it does things. It's usually aligned to a system, and it's not responsive always to people's needs. And so thinking about what's at risk here, my argument is that family medicine, which in the 60s was created to be a movement really to create more community-centered care, to fill in the gaps for people who needed more continuity of care, is now at risk of also being absorbed into institutional priorities. And I think that we see that in the ways that our visit times are shortened. I think we see that in the way that our billing is being structured. Ultimately, we're being pushed to do the very things that we're born to try and resist. And so I think we're at actually a pretty critical moment in time where, as family medicine providers, we do have to decide, like, do we allow ourselves to be absorbed into these institutional priorities, or do we sort of remember our origins in the sense that we're really trying to defy those things? And my argument is that it's imperative that we choose movement. So a healthcare parallel. So when I think, again, back to thousands of years ago, the healing systems that were in place, the care that was happening then, the word that I might use to describe that is healing. And then we moved as Western medicine evolved into this concept of medicine. And that is really, in the grand scheme of things, a newer concept. And we're really at this crossroads where we can become this industrialized system that has much different priorities than if we were a full-time practice. So I think overall, I think of efficiency a bit like a disease, and we need a cure for it. And my argument is that soul aligned practice is that cure. And soul aligned practice is relational, patient-centered, it's holistic, it's community-rooted, it's justice-centered, and it's aligned with inner life, meaning that it works for the people who are part of it. What that looks like, or practicing a soul-aligned practice, it really transforms how we listen to patients, how we structure our days, what our day-to-day work day looks like, how we measure our success. Like, are we measuring our success through economic gain? Are we measuring our success through patient outcome? In what way? It changes how we relate to our communities. How do we feel about the communities we serve? How do the communities we serve feel about us? And then it also impacts how we understand healing. And I think that's something that we don't always reflect on enough also through medical education is like, what does that mean to us? And I wish that every medic, if I was in a high position of power, I would ask for every medical student to take a philosophy of medicine class. You could really think about those things, because I think it really does dictate the way that you practice when you're really thinking about like why you're doing what you're doing on a daily basis. So in closing, I would argue that burnout is the soul's rebellion against inauthentic work. And inauthentic work really happens when it's soulless. And it really requires that soulful presence to feel authentic and to feel meaningful. A final quote from Thomas More: soul is found in depth, value, relatedness, art, and personal substance. And then just a closing question to contemplate. What does your soul need to practice medicine well? I wanted to leave some time at the end here, more than open to hearing any kind of reflections about that. whether those thoughts are good or bad. Any stories that maybe came up for people during this? Of course, question.
I just wanted to say thank you. I thought that was excellent and so encouraging. Your perspective.
Yeah, I also want to say thank you. That was great. I love the history and seeing kind of where the country was to bring in family medicine and remembering that family medicine is not like this ancient specialty. It was a relatively new specialty to bring the center back to specialists. And you know, I mean, I know for myself, obviously, I was so transformed the other night, like, had faculty members introducing themselves to me that they never met me because I did transform a lot in discovering, like, lifestyle medicine. And so a lot of what you're saying is also lifestyle medicine, right? It's ultimately, we have to have purpose in our day. And a lot of what you're saying around social prescribing, for example, is evidence-based. I mean, you only have evidence on things that actually get studied. And when we have a Senate that we currently have that doesn't really fund things like social prescribing, we don't have the evidence, but now we do. And I also really want to encourage kind of what is the next step after your inspiring words? Like, how can we, and I'm looking at you know, how do we bring more soul to what really is a very hierarchical institution where primary care kind of has its marching orders? And I know that's what you're always trying to balance that, but I'm just wondering how much flexibility do we have in our system to maybe bring in some of these alternative ways of practicing?
So this is Dr. Tapia stuff. So, but I was gonna make a comment as well, a question. But if you want to respond first, or you want me to?
I didn't have to let you respond. I think my response would be very different as someone who's not actually in the business. But I would argue that not only are we smart people, but we are also creative people. And I think that if we're willing to be creative, like there are ways to find flexibility around those things. And I would love to like have the opportunity to be able to help think about those things. I think it really is again just about finding the willingness and the people who can actually like make certain things happen.
Yeah, that's great. Yeah. So my comment, my question for you is going to kind of revolve around that. So I feel like I have spent my career trying to figure out how to have a practice that aligns with my soul. So I think thank you for kind of coining that or that phrase and you know, describing that, because I feel like that is what I've been pursuing. And you know, I feel like that it has always been hard. It's always been a lot of work. And I don't think it is getting any easier. I think it's getting harder and harder to do that. And I think my question for you was going to be, I was going to sort of comment on that regardless whether anyone called me out or not. But my question for you as a resident and a future leader of family medicine, and maybe others can comment on this as well, is what do you see over the next 20 years for your career? You know, me looking back at my career over the last 20 years, I kind of think about that. What do you see in the next 20 years? Because I actually think we're in a really risky position too for family medicine.
I definitely think about that a lot, and I think even if I thought, okay, the next 3 years, like thinking of this point, okay, I have to graduate, I have to make a decision about what I'm gonna do and attending it, and I will be honest, like I think that I have thoughts about the direction I'd like to head. Do I maybe fully understand how naive those thoughts are or not? Probably not. But I think that I'm also someone, I would assume like many people who have made it to a place of like practicing or being a part of this healthcare system with that comes a lot of ambition and like the drive to make things happen. But I see myself, and I think I mentioned something along these lines a little earlier, where it's like, well, what kind of a practice am I willing to accept for myself? And I think that for a lot of reasons, private practice is something that's dying and is like harder to access or maybe to make a reality. But that's the direction that I'm thinking about. And for me, it maybe comes from realizing like, okay, if these current systems are not exactly working or not exactly like giving us that opportunity to have that type of practice that we want, what's stopping us from creating our own? And I think there's a lot of maybe personal decisions that come with that. For me, I think it's a lot of like thinking like, well, maybe I have to give up the idea of having a six-figure salary or something. And I think that's harder for people who have families or other things to think about. But I think that it also comes a little bit with like what I'm prioritizing in my mind. And for me, I would rather, I think, have that feeling that I'm doing something that aligns with my soul rather than feeling like I'm getting those other gains out of it. And so I guess I envision a world where I can create a practice that lines up with these things that I want. Maybe I'm not getting all the benefits I would get if I was at a big established corporation, but maybe starting things like that more and more creates ground to have like larger scale operations like that, where more people can be a part of it, where more patients have access to it. So I think it all maybe comes back to creativity at this point, but believing that those things are possible.
Jackie, that's great. Online. Oh, Jackie, we're not hearing you.
Hi, yeah, thank you, Dom, for opening up this discussion. I think this has been on the forefront of my mind for a long time, whether like appointment-based outpatient care practice is even the way to go. And I can see how we started out with the model because there's just so many patients needing a primary care doctor that if we don't stratify or limit our resource, which is time somewhere, then not everybody can be seen. So on an equity standpoint, it could be like perceived that way. But as I rotate through urgent care and emergency room, I also wonder if a more rotating door model can be more appropriate. I'm just thinking of like if people truly give their health the attention and time it deserve, then maybe a medical doctor appointment shouldn't be confined in a 30 minutes time slot so that they can rush to their like work immediately after. So all your discussion about like managing stress and like healthy lifestyle habits and all that go out the window as they rush to their work immediately after the appointment. Um, so all that sound like rambling, but I thank you for opening up the discussions and giving us an opportunity to think and ponder.
Still can't hear you, Jackie. If you want to type it, somebody could probably read it out loud. And then Dr. Tapia, while Jackie's putting that together, I just had a question for you. So as you're kind of contemplating like what a future practice could look like, there's a lot of different models of healthcare that's out there. One thing that immediately comes to mind for someone with like that soulful search like you're after is like direct primary care, concierge-based medicine. I'm wondering if you've ever I'm sure you've had thoughts on that. One of my concerns with that type of style of medicine is perpetuating some of those inequities that you highlighted with the inclusion of hospital-based systems, where we start to select who is coming to our doors because we also need to be funded. Who has money to pay for this? Usually people who are pretty good. And so thinking about carving that out, what are some opportunities that you could potentially service your clinical system while still opening the door for the rest of the community? And then what is the community that you're looking for? Is that a community that you heal and move on and find the next, or is it a community that you heal and continue relationships? So kind of two questions.
I definitely love the idea of like finding community that I'm planted in for good. Like I've more and more thought about going back to my hometown. I think right now that's the path that I think I'm heading. But I think that, and I think this maybe even integrates to what Khan was saying a little bit too, was like, it does make sense, right? Like our time is limited. It's a part of that short appointment time, you could argue, is to make sure that everybody can be seen. But I also think that there's an argument that we're all aware of that if we are engaged with our communities and if we're really doing the work of like preventive medicine or making people engaged in caring about their health, in some ways we're probably limiting the amount of care that people need in a primary care setting. Maybe not immediately, but in the long run. And then certainly that is something I've thought about. Like I think the direct primary care is probably the first thing that comes to mind when people are thinking of like, oh, I want an alternative practice. That is definitely something like I do not want to also create a practice that then like certain people can't access because they can't afford it. I will say that my ideas for myself are very radical. Like I honestly, in the way that I would think of like combating that is like, okay, maybe I don't know, I'm just gonna I think speak in like really gross terms, but say a family medicine doctor makes $250,000 a year on just seeing your average patient. Like I don't know if it's just my background, but to me that's like a wild amount of money, like more than I guess I would think I would necessarily need. So it's like even if I saw half of the patients and made half of that money and had half of my time where I could offer people free services like that, I think is something that I'm open to doing in my practice. And I don't think that we necessarily think about the ability to just be able to offer people those things.
Yeah, I mean, there's some sacrifice. This also kind of comes to the ethos of medicine too, where we put the patients first, right? It's not them. And we take an incredible amount of sacrifice through that. You know, we can visualize it by like our training environment right now and the type of work that we're doing, but you can look at it as opportunities like this where you are embraced and you're part of this community and you're giving yourself to this community. And that's going to take away from your time. There's other opportunities and things that you can do for that. You know, I think a lot of the people that are wiser and smarter than me kind of like, you know, think about funding models and all that kind of stuff. And I wonder if this is an opportunity for you to really try to leverage the folks who do have some cash money, you know, some of that philanthropic work to fund something. We'll see if this can grow over time in a community. You could partner with somebody from your hometown that maybe is sitting here or sitting somewhere else. You know, could be cool. I also want to say that, you know, rural practice looks a lot different than what we do here. And this kind of echoes a little bit of rural practice here. So hopefully you find that.
I just want to chime in with Jackie's comments. I think it aligned. She said, great talk, Dom. And I'm reminded of one of my faculty, Stu Farber, who started palliative care at UW Medicine. He used to say that palliative care is just family medicine on steroids, and palliative care saves healthcare systems money. So maybe so do the local practices.
I was wondering if you think there is a connection between some of our peculiar American obsessions with individuality and privacy that have become very much part of our medical system, and if there's this connection between lack of soulfulness and the community connection and that. I talked to a doctor recently who is trained in Iran, and she said her first impression of coming to the US medical system was she walked into a hospital and she said, well, I'm on the oncology unit. Like, where's the living room area where like all the families sit around and drink tea together? Because that's what they have in Iran. And then she walked to a maternity ward and said, like, well, where's the area that like the new parents sit together and have connections? And she saw like the nurses scooting all of the new mothers and their babies like back into their rooms, like back into your room. You can't violate anyone's privacy by being out in the hall. And I wonder when we really have this concept of like one person in an exam room, and we've done some work in group this, but I wonder how much of the problem of like efficiency and community and soulfulness could be solved by breaking down that obsession with individuality and privacy that can get in the way of forming communities.
I think those are bigger ideas that I think about too, like, and maybe the thought that comes to mind is like, in a lot of ways, I see the healthcare system as like a microcosm of society. And a lot of the things that are going on in healthcare are really just reflective of our broader society. And I think that's exactly what you're talking about. And I see a lot of, I guess I would say, direct analogies between the two. So like you could think about tackling things on a healthcare level, but it is also really also thinking about like how are we viewing these things on a societal level? Like how are we viewing medicine and healthcare and healing on a societal level?
I just had a thought, in making, I'm very much for the model of care that you were sharing with us, and it's really encouraging to me because I think, previously before being a medical assistant, I was in massage therapy, and so there were other modalities and ways of managing stress and the body and things like that. Being in tune that I kind of pulled in with me as I went more to more of the Western medicine model with, being a medical assistant. And I've always found that there just needed to be this convergence of both of those worlds living together instead of so separately, because we're such a unique systems individually, that it requires multifaceted care. And but I will say that as we're maybe trying to strive toward this other model of how we view things, what are some micro steps that we can take to make small adjustments so that over time we see this progress toward that way?
I think the thing that comes to mind, and Dr. Godfrey had touched on this a little bit, is like, and I think that during my talk, this is where I was going with like this obsession that we have during our training with evidence-based medicine. Like, yes, evidence-based medicine is great. Like, it saves lives, it keeps people safe. But that obsession can also turn into just because something is not evidence-based, it is not beneficial for someone. And as Dr. Godfrey mentioned, a lot of times the reason that something is not evidence-based is simply because we have not prioritized the research for that. And so I think it is inviting that more. I think whether that's, on a personal level with our patients, whether that's like with our colleagues, just having more acceptance for those things is probably the first micro step that I would think of. Yeah.
Maybe one more, with last minute, if anyone else has any other questions.
Well, my question, thank you so much. My only regret is I missed your first part. I have always considered myself a practitioner of what you're describing. I have the suspicion, however, that much of my equanimity in my soul is directly fueled by the agitation in my soul. What is the role? And what I'm not sure the notion that we create an environment that makes our soul happy is actually the thing that we are striving for. And that many times my bringing my soul into a room filled with agitation, if I want to be accurately aligned with that, I need to bring that same energy. What are your thoughts on the role of an agitated spirit?
I think that I understand exactly what you're saying, and if I do, I guess I can maybe only speak through like my experience and the way that I think about it. And I do agree, like healthcare and medicine is not always a happy place. Like we are often choosing to put ourselves in situations that are maybe taking away from our peace, like on a surface level. I think the thing that drives me is not so much thinking like my soul needs to be happy, but in order for my soul to feel fulfilled, something that brings me fulfillment is knowing, or at least feeling like I'm working toward reducing the amount of suffering in the world. And I guess that's how I make sense of that. It's like even if I'm feeling that temporary unsettlement, I'm ultimately feeling fulfilled because someone's being helped and I'm being helped in that process.
Thank you so much. You can see me, you can see how to claim, and then we'll hopefully see everyone in January.
Yes.
What anything.